Gastroesophageal reflux disease is a fairly common disorder in the United States. It has significant impact on people's lifestyle and is also a pre-malignant lesion, so it becomes pretty important. So even though this is just one cause of esophagitis, we're giving it its own lecture. What I want you to pay particular attention to is when you do which intervention. And you'll see what I mean once we round it out. So gastroesophageal reflux disease is a product of acid. You have a weakened lower esophageal sphincter for whatever reason. And then acid is going to regurgitate into the esophagus and burn the esophageal mucosa. That burning hurts, and that leads to esophagitis. The patient is going to experience one of two things. The first is going to be the typical symptoms. And that is going to be the symptoms of the acid coming into contact with the esophagus. That's the burning that hurts. They will experience a burning chest pain made worse by laying down, by being recumbent, and by spicy foods. It is improved by sitting up and antacids. Now that makes sense, right? Because gravity helps pull the acid down into the stomach from the esophagus when upright, and neutralizing the acid would make the burning not as bad. Whereas if you laid flat, the acid is allowed to roll out of the stomach because there's no gravity to help you, and spicy foods stimulate acid production. So what you're looking for, typical symptoms, not hard to spot. But atypical symptoms may trip you up. Because that acid comes into contact with more than the esophagus when they're laying down, it can roll up and touch other things a little higher up, like the larynx and the trachea. So you might experience hoarseness, coughing, and a common cause of chronic cough is actually GERD, and even stridor if it gets really bad. But where they're going to go in the test, what you should look for, is nocturnal asthma. That is, the patient has all of the symptoms of asthma, coughing, wheezing, dyspnea, but only at night. They're symptom-free throughout the day, and no matter what you do with the asthma medications, they don't seem to get any better, except it's only happening at night. Nocturnal asthma is GERD. Okay. You make the diagnosis, and this is another selling point for the test, you make the diagnosis of GERD not by doing a diagnostic step, but by treating it. You choose proton pump inhibitor and lifestyle for 6 weeks. You choose PPI, proton pump inhibitors. PPIs have been shown to be better than H2 blockers and placebo, so you use PPIs. And also notice it's not try lifestyle. And notice it's not try lifestyle modification first. It's PPI and lifestyle. And the lifestyle stuff you want to do are things that reduce the lower esophageal sphincter from opening. Avoid chocolate, peppermint, smoking, and alcohol. And you can do some other things like raising the head of the bed by 30 degrees. That helps you while you sleep. Or don't have a large meal before you go to sleep. The point is those lifestyle modifications don't necessarily do much for the disease. They might make the patient feel better. But it's the PPI that is the treating step as well as a diagnostic step. Now, if this doesn't work, you need an EGD with biopsy. You see, the EGD with biopsy is only going to show you esophagitis, and it will have eosinophils. It's not going to prove to you that the esophagitis is a product of acid, only that the esophagitis is there. So if you really want to make the diagnosis, what you need is a 24-hour pH monitor. That is, the patient wears the Holter device with a thing down their esophagus that measures the pH. They keep a diary of their symptoms, and if it lines up with you have symptoms with low pH, diagnosis done. If you're going to do a surgical procedure for GERD, you'd also get manometry to make sure that this is what you're going to fix. In general, don't pick manometry. What you want to go for is the PPI and lifestyle changes for 6 weeks, and only then do an endoscopy. But there is a way to skip the PPI and just go straight to endoscopy. And that is going to be the patients who have alarm symptoms. And what you're concerned about with alarm symptoms, that this may be cancer or something worse than just GERD. After you do the endoscopy, you're going to get some results, and you're going to see this as a spectrum of severity of how bad GERD can get. If what you saw was just GERD, all you need to do is treat with the PPI. The same is true if that 6-week therapy happened to work. But if you have metaplasia, that is Barrett's esophagus, you need to increase the dose of PPI, generally high dose, twice a day. If instead that GERD has caused dysplasia, it's turning into cancer, you need to do local ablative therapies. And it doesn't matter what you use, whether it's radiofrequency ablation, a laser, or cryo, you essentially burn away and remove the dysplastic tissue. Because if you don't, dysplasia turns into cancer, and that is adenocarcinoma, where you have to stage and resect. And because this process can always continue so long as there's more acid burning the esophagus, when you're here, you're going to need to do surveillance EGDs. All right, that last part was probably pretty confusing. What the hell are you talking about? Why does GERD, metaplasia, dysplasia, why does that happen? Why does that happen? It happens because acid burns the esophagus. It's constant inflammation, and when you have constant inflammation, you have the setup for cancer. So most patients who are going to have these symptoms just have GERD. But the esophagus is not meant to experience acid. And so for over years and years and years of having GERD, the esophagus finally says, dude, I've had it. I'm tired of being burned all the time. I'm just going to change to something that can handle the acid. And so what happens is that the normal esophagus undergoes metaplasia. It turns from the normal mucosa of the esophagus into the columnar epithelium of the duodenum. Duodenum, after all, receives acid all the time. It doesn't care. So the esophagus changes from esophagus into columnar cells, from the esophagus to the duodenum. That change is called Barrett's. Barrett's esophagus is the metaplasia to the wrong type of tissue. It's actually a physiologic response, and what might happen is that the person has unrelenting GERD and then gets better all of a sudden on their own. That is what happens when Barrett's happens. Right? The esophagus doesn't get burned anymore. It's like the duodenum, so the patient doesn't feel any pain. But whenever you change a cell to something else, that's a setup for precancer. So once you have that metaplastic change, the patient is at 30 to 50 times increased risk for the development of adenocarcinoma. Full-blown cancer. That is dysplasia, not just metaplasia. Okay, let's do it again as an algorithm, because I want you to really drill this into your head to get this right. Patient comes in with the signs and symptoms of GERD. They've got a retrosternal burning chest pain, worse with spicy foods and laying flat, better with sitting up, and an acid, metallic taste in the back of their mouth, nocturnal asthma. You say, you've got GERD. You try PPI and lifestyle for 6 weeks. If this works, they improve. Say congratulations, all you had is a little GERD. And then you continue them on the lowest possible dose of PPI, and that could be none. If, however, they fail to improve, now you want to make sure it really is GERD, not something worse. So you do an EGD with biopsy. But you can jump and bypass the PPI if there are alarm symptoms. And the alarm symptoms are nausea and vomiting, anemia, generally microcytic, or weight loss. Signs that this might be cancer. They go straight to EGD with biopsy. And the EGD with biopsy is going to show you one of 4 things. On the good end, it was GERD. Same thing as this. You put them on the lowest possible dose of PPI, including taking them off it. Most patients will get off the PPI. On the opposite end of the spectrum, you've got adenocarcinoma. This is cancer and is treated with staging and resection. An advanced stage gets chemo and radiation. But here in the middle is this change from normal tissue to cancer. And that is going to be metaplasia, Barrett's, and dysplasia. Now it's a little more complicated than this because you have to grade the dysplasia, how bad it is. But what I want you to learn, keep it simple, is that if it's metaplasia, Barrett's only, you're going to do high-dose PPI. If it's starting to get to be cancer, you do local ablation. And of course, you're going to do the PPI here as well. But regardless, at metaplasia and dysplasia, you're going to need to keep doing endoscopies, surveying for worsening change. If they're doing well, they need them less often. Metaplasia GERD, every 3 years. If they're doing metaplasia to dysplasia, they need them every year. And if they're starting to have some pretty nasty cancer-looking things, it's even more frequent. Don't memorize the schedule, just know that the frequency increases the closer you get to adenocarcinoma. And now, this whole time, you have to think to yourself, could this person be surgically intervened on? We mentioned that by getting the manometry before you go to surgery. The Nissen fundoplication. This is a caveat treatment. Remember, PPIs are what you use to treat GERD. Not H2 blockers, not calcium carbonate, you use PPIs. They're the best. If a person cannot tolerate PPI or doesn't want to, then they do the Nissen. In the Nissen, you just grab the stomach and literally wrap it around itself, creating a tighter LES. Now, of course, the risk of that is tying it too tight, and then you get achalasia. It's not the pathology of achalasia, but it's basically the same symptomatology. So if you're thinking about doing surgical intervention other than resection, it has to be because the patient wants to or they can't tolerate PPIs. That's GERD.